We're going to do critical care ground rounds today. Josh, welcome to the Stony Brook EM residency.
Thank you.
Josh is one of the smartest guys I know in critical care. He's going to be all humble and deferent on that, but it's absolutely true. I learn from him on a constant basis. He's an associate professor of medicine in the Division of Pulmonary Critical Care at, what is the actual hospital's name in Vermont, Josh?
UVM Medical Center. They keep on changing it.
Yeah, I know. I can't keep track. He, in addition to his clinical work, is, I think, best known for his blog, PulmCrit, which during COVID at least may have been the most popular resuscitation and critical care website not owned by a society in the world. I think that's fair for us to say. What do you think, Josh? Is that going too far?
Thanks, man. I'll go with it.
All right. And this is Josh's second Grand Rounds appearance at Stony Brook. The first one was phenomenal. And we are super lucky to have him today. We're going to do it in question and answer format. I have a set topics I'm going to hit him on, and I'll start the initial foray of questions. And then for each one of those, we'll open them up to the group for any additional questions on that topic. And then we'll have time at the end for questions on any topic you like. Does that sound okay, Josh?
Sounds great.
All right. My first question is a softball question before we get to the hard clinical stuff. But you've made your academic output through this blog, and you've touched people all over the world. And my question is, if you had the same career 20 years ago when blogs on the internet didn't really exist, what would you be? Like, would you be thwarted? Would you be this like grumpy soul who has no outlet to the rest of the world?
Yeah.
What do you think would have happened?
Yeah, I think I would just be like an old curmudgeon, like wandering around the hospital, yelling at residents, telling everyone they were doing things wrong.
All right, let's get into the clinical stuff. Now, you have been working on, and it's soon to debut, a real treatise on the critically ill atrial fibrillation patient. And so let's start the conversation there. But we're going to shift your venue. You're doing a moonlighting shift in the emergency department. So they're not already in critical care. They're not as differentiated as they may be when they get up to your unit. And a patient comes in and they're hypotensive and they have atrial fibrillation at 160. So let's give you vital signs of 90 over 65. So their MAP's above 65, but they're clearly not great. And they're super tachycardic. Walk me through how you approach that patient.
160, I'm not sure I'd call 160 super tachycardic.
Okay. What would be your adjective?
Like 190, something like that.
Okay. What would you call 160 though, is my question.
Like mildly fast with AFib.
Okay. Fair. So go for it. How do you work up this patient?
So I think it starts the same as with any patient. You want to start with your history and physical examination. What happens? Is there something underlying this? And I think the real money question here is always, is it the AFib causing the instability, or is the patient unstable for some other reason like pneumonia or gastroenteritis or pulmonary embolism or DKA or something else, and that kind of caused them to be in fast AFib? So I think as much as possible, trying to get a history, figure out what the underlying problems are. Is this someone who's like on a golf cart happy and then they suddenly popped into AFib and fell apart? Or is this someone who's been like vomiting and nauseous for 3 weeks and now they're dry as a chip?
Yeah, the real pain in the ass comes from exactly the question you just mentioned, which is, are they hypotensive from their tachycardia, or is their tachycardia the secondary symptom of why they are hypotensive? So how do you figure out, should you acutely lower their heart rate or not? What makes the determination of, oh, wow, this patient's probably just compensating for their bad sepsis?
I think history is really useful. If there is some explanation for why the patient's sick, if they have pneumonia or if something else is going on, then usually my assumption is going to be that's the primary process. And then physical exam, I think, can help you too, just taking a look at the heart. Are they totally empty intravascularly? Is there some cardiac problem that could make them more unstable with AFib? So there's some people out there with like bad pulmonary hypertension or, severe mitral stenosis or really horrific critical aortic stenosis who are actually like legitimately destabilized with AFib. So I think that would push me towards saying the AFib is the source of the instability. And then I think the other thing that goes without saying is you're going to look and see if it's AFib with WPW, because that's like an entirely different beast. And that's like its own topic.
Is there a heart rate that you would say clearly the hypotension's not from this heart rate?
I think as a general rule of thumb, I use 150. If it's under 150, I think it's increasingly unlikely that the instability is due to the AFib, unless there's some sort of really horrific underlying structural heart disease.
Let's take a situation out so that we don't have to deal with it for the rest of the time. And I know AHA has their ACLS guidelines for who should get an immediate shock, regardless of the fact that they haven't been anticoagulated. And there's a lot of the patients they would include that I could say, I can manage this without shocking this patient. So who do you immediately cardiovert?
I would immediately cardiovert, probably AFib with WPW. And if the patient was like insanely fast, like if their heart rate was like north of 200 and they look like they're going to die like within the next 5 minutes, then I might shock them. But honestly, like that's not something I see. Maybe I would see it if I worked in the emergency department. And this is one major challenge of AFib, by the way, just taking a step back, which is that AFib is like the wise men with the elephant, where I see some AFib, you see some AFib, there's outpatient AFib, there's AFib on the floors, and these are different animals. So I must admit, like in the ICU, I don't see these patients, these like mythical, creatures that like get a DC cardioversion and get better.
We don't see them that often either. I think, okay, to be fair to the AHA, I think if you're not an experienced provider, the idea of what you and I would do in these patients, which we'll get to shortly, seems a bridge too far when they're advising like what to do for a family practitioner who may see like a sick AFib patient once in a while. And the patients we avoid shocking, it may be best for them to just have a easy to write on a flowchart paradigm of just they're unstable in any way, shock them. But you could be a little bit more nuanced if are willing to try pharmacological management in these patients. So that brings us up to the next question. Let's say you have a patient, you're convinced their heart rate is compensatory for something like sepsis. It's the equivalent of sinus tach in a patient who doesn't have structural heart that likes going into AFib. And they start off at 160. It still seems, even though it's a secondary thing, not great to leave them at 160. Let's say the patient's 80 years old. What heart rate do you shoot for to bring those patients down to?
So that is like the $1,000,000 question. I've looked this up. I've tried to look it up. I cannot find evidence for it. As a general rule of thumb, I like to get folks under around 130. I'm very happy with people being 110 to 130 if they're sick, but I don't have good evidence for that. That's arbitrary. And if the patient's in 140 and they're doing great and they're clinically improving and they're making urine and mentating, that may be okay. Probably over 150 is not super awesome, but this is, is anyone aware of any good evidence on this? It probably depends on the patient, what their heart is, stuff like that.
I've not seen any evidence. For old people, I like 110. It's a nice place for them to sit. And I agree with you. For younger patients, they might even do great with 120, 130. It might be augmenting their cardiac output. Just as a side note, Peter Vecellio mentions that the ones who are truly going to need a shock, and you alluded to this, Josh, are the patients with valve disease who, especially the stenoses, mitral stenosis or aortic stenosis, who just don't like tachycardia at all. So we'll just put that out there. You have a patient, you think their hypotension is as a result of the atrial fibrillation, but we're more nuanced. We don't need to immediately shock that patient. Maybe they're going 180 or the 190 you put out there is super tachycardic, and they're old, and but they're not dying. So we figure we don't have to shock them right away, but we do have to fix this heart rate. We really feel their hypotension's from the heart rate. What's your management?
Yeah, so probably I like phenylephrine infusions here. They'll increase your blood pressure. They'll buy you some breathing room. I love magnesium, so I'd be inclined to give the patient a couple grams, maybe 4 grams of mag, depending on what their renal function is, maybe a little potassium. Take a look at the patient. Anything that's fixable, you should fix. So lots of times I go into the ICU and I see people like struggling with amiodarone and the patient's on dopamine infusion, or they're super anxious or something like that. So really, I think the key, probably the most important take-home message perhaps from this is like when you see an AFib patient and their heart rate's uncontrolled, think why and treat all of the things that are contributing to it. Treat their sepsis, give them volume, all those things. And a lot of time that alone will get things better. If that doesn't work, then I must admit, I like to use amiodarone. I know that's not a popular drug in the emergency medicine department world, but I don't know.
No, we'll get there, and I'm with you. So you're in good company, though the two of us don't make good company necessarily. In fact, most people in organized emergency medicine would say we make bad company. But let's go back to your MAG for a sec before we go to the drug choice of rate control. Will that cause hypotension to give these patients acute bolus of magnesium? And will the phenylephrine take care of that, and so we don't care?
I think theoretically it's possible that magnesium can cause vasodilation and hypotension. I don't think I've seen it a lot. I think it's a pretty safe medication. When you think about all the different drugs you're going to be throwing at these patients, I think magnesium is probably one of the safest ones. And maybe you'll push up your phenylephrine just like a little bit temporarily. But I think magnesium, I love it because it probably helps you with rate control if you're going to do that. It probably helps you with rhythm control if you're going to do that. It's pretty safe.
All right. Now, I also, for critically ill patients, like 150 boluses of amio. I may never start them on a drip. And then sometimes the cardiologist will come down, especially the cardiology fellows, and actually say you can't ever use amio in these patients because it's going to convert them. I found amio to be crap for conversion. And therefore, the risk of that in these patients, it's unacceptable. You need to only use an AV nodal blocker agent. What do you have to say to that, Josh?
Yeah, I kind of disagree with that. So, especially for people with AFib in the context of sepsis or acute critical illness, I think a lot of these patients are going to go back to normal sinus eventually as they recover. So, personally, I think getting whether they go back to normal sinus rhythm today or they go back to normal sinus rhythm in 3 days or 5 days, you could almost make an argument that the quicker they go back to normal sinus, the less likely they are to have a stroke. I've looked for high quality data on this as far as is there any sort of causal relationship between cardioversion and having a stroke? And I don't think that data really exists. So I think overall, I'm skeptical about this whole concept that you're going to give someone like 150 milligrams of amio and like cause them to stroke out.
Do you write anything special on your note to block yourself from the potential catcalling later on, or do you just accept it as I'll deal with it if someone complains?
I must admit, Vermont is not a very litigious place, and this hasn't been like a big issue for us. I think you could always kind of justify it as saying like the patient was in shock and your first priority is to maintain organ perfusion.
Absolutely. All right. So now, when would you use a diltiazem or a beta blocker then? Is it only in really sick AFib patients? What would be your choice on those agents?
My preference is not to use a beta blocker or diltiazem for patients who are unstable or hypotensive. We certainly see a lot of patients who end up in the ICU for some other reason, COPD, what have you. They have fast ventricular rate. We want to slow them down. So I think using a beta blocker or diltiazem is fine for those patients. Although I think if you're going to use diltiazem, you need to pay a lot of attention to the dosing.
Do you want to elaborate on that?
Yeah, I must admit, I hate diltiazem, and it's just like a personal thing, just because we get so many patients who I feel like are hurt by diltiazem. And I think the dose makes the poison here. So diltiazem has a half-life of like 2 to 3 hours. And what I see a lot is patients get like a couple boluses of diltiazem. They're doing okay. They get put on a diltiazem drip. They're doing okay. Their heart rate's like a couple clicks over what you want it to be. It's 115. Someone writes diltiazem drip 5 to 15 an hour for target heart rate of 110. And then the nurse will crank it up to 15. And then 4 hours later at 3 in the morning, all the diltiazem will accumulate and the patient will have a heart rate of 50 and they'll come to the ICU. So I feel like it's nicardipine. It's one of these drugs that has like a half-life of a couple hours. So it's not great to give it as a drip. It's not great to give it as a bolus. It's just like a little awkward.
Diltiazem is the drug of choice for emergency medicine, non-critically ill rate management. So I think this might be a situation where you only see the bad of this drug, and that selection bias might alter that. But I agree with you. For critically ill patients, I like amio a lot. If you get them under control and they're better now with the amio, what do? Do you put them on an amio drip? Do you add a different class of oral agent? What's your...
So it depends. There? If the patient's cardioverted out and I want to keep them in sinus, my inclination is oftentimes to continue amio for about a week until the patient's better and their sepsis is resolved, just so they don't flip back into AFib. If amio is just being used for rate control, as the patient improves, you can probably lateralize it to like a beta blocker or something like that pretty quickly.
I'm not a big fan of metoprolol just because you run out of runway real quick and then you're left with having to either go to another class and now mix drugs or just stop. And so what's your feeling on beta blockers, and would you prefer esmolol in a really sick patient?
Yeah. So theoretically, esmolol is great. It has a short half-life. I got to admit that like in practice, I haven't really used it a lot, and I find it to be a little laborious. In order to do it right, it takes a lot of work. You have to bolus it and uptitrate, bolus it, uptitrate, bolus, uptitrate. And in practice, that just like hasn't worked out for me a lot in my practice context. So I don't tend to use it. And honestly, I think it's easier in some ways, and it's also pretty expensive. So you could almost make a cost argument that you're better off just giving metoprolol. And then if the patient gets hypotensive, just put them on like a 2 mic epi drip for like 4 hours. You probably save money.
We get a question now from Peter again, which is, would you make your drug choices based on the patient's pre-existing pharmacology, their medications they're taking? If we're hearing from cardiology always, this patient takes a beta blocker, so you can only use metoprolol, not diltiazem. What are your feelings on that?
I think there's some validity to that. I think there are some patients who respond better to one drug or the other. And these chronic AFibers, a lot of them look at their drug. First of all, look at the amount of drugs that they require. And I think that helps you a lot. So for example, like if a patient's in chronic AFib and they're on no medications, they probably have a crappy AV node. So be careful about that. Alternatively, if they're on like a truckload of metoprolol, a truckload of diltiazem, they probably have really difficult to control AFib. So be aware of that. And if I do encounter a patient who's responded better to one or the other, I think that makes sense to use whatever they've, responded to before.
Josh, what else are we missing on atrial fibrillation in critically ill patients that you want to discuss?
So I'm interested in the use of ibutylide as for chemical cardioversion. I've seen this used a couple times, and I think this has potential utility in the ICU. Not necessarily so much the ED. In the ED, procainamide seems to be an easier drug because you don't need to observe people for so long. But I am interested, and I think the literature would support greater use of ibutylide for chemical cardioversion in the ICU, especially paired with magnesium. Is that something that you've seen?
I think it's on its way out because they're better agents that fill the same role without the possibility of the QT prolongation. And I think you're going to see the advent, because in Europe, they're using a bunch of the other agents, some of which I can't even pronounce. But I think there are better
Yeah.
agents for chemical cardioversion that are in the cardiology world. All of them, except ibutylide, and maybe this is why ibutylide is such a happy emergency medicine drug, require the dichotomous decision that the patient does not have structural heart disease. And I don't quite know what that dichotomy is, but that's the thing, is all of these other newer agents that potentially work better, have less side effects, less monitoring time, all are banned in patients with quote unquote structural heart disease. Procainamide's nice because your problems occur during the administration, so you can monitor them. And once you turn it off, you're pretty much good to go. I like that. But got to say, I'm a big fan of just shocking the hell out of them and being done, even though the Canadian studies would say start with a chemical first priority. So what do you do in the ICU in the same scenario where it's just a patient who had no atrial?
You muted yourself.
How much of that did you get?
When I'm in the ICU, the patient, and then you.
Okay, great. Perfect. So then I just lost it at the very end. So when you're in the ICU and they had no AFib, they slip into AFib, maybe the epidose was a little bit too high, and it's a young patient. Let's say they're like 45. Do you shock them out, or do you try to convert them back to their native rhythm?
So what I like to do is, first of all, you're going to do all the basic stuff, stop the epi, whatever, treat whatever underlying problems you have. I actually like to put these folks on a protocol called Magnesium Infusion, which is a little wonky and it like surprises people, but there's actually pretty decent evidence for it. It's a safe thing to do. Once your nurses do it a couple times, it's pretty easy to do. So I'll start out with the mag drip, let that go for a while. And then I do like to try to use amio to convert them. Now I find that the first 150 of amio usually doesn't work, but once you push to 300 or 450 of amio on top of magnesium, they will oftentimes convert.
Cool. And are you anticoagulating?
That is such a huge boondoggle. There's no good evidence for what to do with anticoagulation in the ICU. I think the most recent studies and the Canadian guidelines suggest that for patients who are in acute AFib due to sepsis or an acute illness, anticoagulating seems to increase bleeding without a measurable benefit. So I've moved away from anticoagulating, although it feels wrong.
And to speak to the EM side of it, the same Canadian guidelines that Josh is mentioning, actually for ED conversions, even in a patient with a low, whatever CHAD VASC version you want to use, are now recommending a period of anticoagulation. Not as a definitive and not with high level evidence, but they are the first ones to put it out there that if you do a cardioversion on a patient who had a bender last weekend, that you're actually supposed to send them home on an oral DOAC or something similar. And I don't know what to do with that because A, we're not Canadian, and B, there's no real evidence for that recommendation, but it is something I think worthwhile to put in your note saying I had a shared decision-making conversation with the patient and he or she decided not to opt into the DOACs. Or if they're like, yeah, whatever you think, doc, then putting them on 3 or 4 days. Josh, we're lucky. We get cardiology follow-up or any follow-up really instantaneously in our venue. So you can put them on 2 days of anticoagulation and let their cardiologist figure it out. All right, let's open it to the group. Any questions about sick patient AFib?
Hey, it's Armand. So I typed in the side, but how about DIG? What do people think about that?
I like DIG. I think there's a definite niche of patients for whom DIG can be great. So I find DIG to be useful for patients who are in chronic AFib. DIG tends to push people into AFib and push them away from cardioversion, and it can cause big problems theoretically with cardioversion. Someone who's in chronic AFib with systolic heart failure, who is like hemodynamically tenuous, I DIG in those folks. It takes a while to work. So they need to be someone who has a heart rate of 150 and you're trying to get it to 130 or 120. But It's pretty safe in the ICU context too, because you can monitor DIG levels really carefully.
How much do you give and how long would you keep them on it?
So the dose it's about 500 and then 250, 250. It depends a little bit on their weight and their renal function. And my inclination would usually be to keep them on it for a while. Hopefully, for some patients, it could be a good long-term medication, but I think there are a lot of patients where it's just like a short-term stabilization maneuver until they recover from their acute illness. Then you can rotate them onto something like a beta blocker.
All
And
right.
then if the DIG doesn't get you as far as you want to go, as far as rate control, or then does that kind of make things more challenging with other AV nodal blockers or amio? How do those confound each other?
The DIG will confound any sort of effort you want to make toward rhythm control. So I think before giving DIG, you're committing yourself to a rate control strategy. You can combine it with things like magnesium and a beta blocker. So that's reasonable if the patient has enough blood pressure. Combining DIG and amio is a little wonky. Some of my electrophysiologists aren't thrilled with that choice, but I think you could if you absolutely had to.
Cool.
Other
Thanks.
questions in the realm of atrial fibrillation before we move on to our next major topic? All right, Josh, I want to sort through and have your wisdom on pain, agitation, and delirium, because you've been confusing me lately, brother. So let's start off with this case. You get a 40-year-old patient with COVID, and you've been going with the high flow for a while and awake proning, and the patient has been doing well, but finally it's been dipping into the 70s more often than it was. And you're finally like, I need to intubate this patient. You have an entire conversation with the patient. They're obviously completely lucid and they understand. And you're like, no problem. And you RSI the patient and the medications wear off. And now you need a pain, agitation, delirium protocol. Now, by rights, this patient should not have any agitation. Am I crazy here?
Oh, God. So theoretically, we should be able to dissect out all of pain, agitation, delirium, and pain should be treated with an analgesic. Delirium should be treated with an antipsychotic, so on and so forth. In reality, it's super difficult to do. And then a lot of our drugs are really achieving multiple different things. So I think the reality of this is a lot squishier than anyone would necessarily admit, although this is being recorded. And the way I like to think about this is I want to try to get the patient to be comfortable, to look comfortable, and to be okay on the ventilator while using as few kind of detrimental medications as possible. And sometimes I end up using, for example, antipsychotics, kind of using them as sedatives. And I don't know.
Yeah, well, let's go into it. So what would be, the patient we just discussed, your standard pain agitation?
Order set is, I'll start with scheduled Tylenol. I don't know if it does much. Maybe it'll do a little bit. I like to use pain dose ketamine a lot, so I'll put them on 10 or 15 milligrams an hour of ketamine. You can titrate that up sometimes and find a little sweet spot with that. Most patients are going to get some propofol. I like to keep that at a low to moderate dose, especially with COVID. There's some emerging evidence that patients with COVID especially tend to get hypertriglyceridemia. So we're talking like 20, 30 of propofol. And then I like to add on an atypical antipsychotic, like a quetiapine 50 BID. You can titrate that up, or like olanzapine is nice. You can use it once at night and it helps you sleep and it has some residual utility during the day. And then I'll throw on some melatonin just to help them sleep. And maybe that has like some residual sedating effect. And then on top of that, there's going to be boluses of an opioid of your choice, whether that's fentanyl or hydromorphone or morphine.
And that's for all your patients standard, unless they diverted from your routine. That's your
go-to.
That's
the general architecture. There are some patients who need more. There's some patients who are just weirdly comfortable. I'm sure we've all seen those patients who are just like intubated playing cards.
This is fascinating to me. This is, and I haven't seen a post from you that laid out, this is your standard practice. And I have no issue with any of it. It just is a diversion through most people's protocol. So every patient gets an atypical antipsychotic.
I mean, not every single one, but the COVID patients are really challenging. They seem to chew up sedation a lot more than your average patients. And I find that I just like to use an atypical antipsychotic. I think it helps you limit the propofol dose, avoid the hypertriglyceridemia, avoid opioid infusions.
Okay, I might have biased the conversation then, and I just put COVID out there because it's the quintessential patient that had no agitation before intubation. So let's say non-COVID world. Hopefully we'll get back there soon. What would be your standard practice on a non-COVID patient, just a patient with pneumonia who gets intubated? Would it be different than what you just laid out?
It would be pretty similar, although I might be a little bit less aggressive. I might like hold back on the antipsychotic and like see how things go. In a
So
lot
then
of,
from what I'm hearing, you feel the backbone of analgesia in almost all our patients should be a ketamine infusion.
scheduled Tylenol, ketamine infusion. Yeah. If I had my
Okay.
druthers, it's sometimes
Yeah.
hard to convince people to do that in the ICU pragmatically.
I think you'd have little problem convincing us. Adam mentions the New England Journal study. Adam, that Josh just did a post on that, the men's trial. You'll find that it was clearly not a trial in any way of dexmedetomidine versus propofol, unless you consider homeopathy to be a worthwhile thing to study. And that study's interesting, Josh. You and I have vacillated, and I think we've both come to the same place where we no longer like continuous infusions of fentanyl. There's a lot of unnecessary accumulation. You've told us a little bit about your ketamine as your backbone of analgesia. What is your supplementary medications of choice, and how do you handle that?
As far as pain or,
Yeah, as far as pain, I'm sorry.
probably opioids. I think opioid boluses are fine. I'm not against opioids. I think it's similar to the DILT thing. I think the dose makes the poison, where the problem with fentanyl drips is people crank them up and then it just takes a lot of work to get them shut off. I think hefty doses of PRN opioids are okay. You can probably crank the ketamine higher. So as far as the ketamine pain dosing, the standard textbook pain dosing of ketamine, that's based on patients in the PACU or like post-operative patients. And the problem that they're concerned with is if you increase that, patients go into this subdissociative haze type thing and they can get wacky. But if you have someone who's on propofol or dexmedetomidine, that sedative, or especially an antipsychotic, it's possible that those drugs may block the ketamine-induced kind of dissociation / agitation / anxiety. So I think there's probably room to crank the ketamine higher in a lot of these patients.
You haven't really mentioned Dex, and that was always my ICU. It's the one I loved. When do you use dexmedetomidine, and how come it's not your initial foray?
It's usually not my initial drug that I reach for. It's especially as someone's just like getting settled in on the ventilator, it may take a little bit of time to work. It's not quite as like idiot proof increase, decrease as propofol. And I have had some problems with dexmedetomidine withdrawal. So if patients are on like Precedex for 5 or 7 days at high doses, they can definitely withdraw. So my usual inclination is to start out with propofol, get folks settled down. Oh shit.
What's wrong?
Oh wait, sorry. My Zoom thing. There we go. Sorry.
Yep, you're still good.
Cool. Sorry. Get them settled down. And then if I'm having difficulty extubating them, if they're one of these people who, like, when we try to do spontaneous breathing trial, they get really agitated. I think Precedex is great to like bridge people off the ventilator, but it's not usually something I'm reaching for really early.
All right, fair enough. This literature is all over the map, and I don't know quite what to do with it. You might have a better idea of it. So you get a really critically ill patient. They're on very high dose vasopressors. They're on 3 separate agents. They're very unstable. You could barely get a map of 55 with all those agents. And the choice of sedation strategy in those patients, they might be very agitated from their lack of perfusion. It's hard. Now, you could go ketamine drip. Not great evidence on that. My feeling is that by the time you're on 4 vasopressors, there is no vasodilatory effect of propofol anymore. There's some studies that would bear that out, even on lower doses of vasopressor. What do you do in those patients?
My inclination there would probably be to go for a high dose ketamine, like a dissociative ketamine drip potentially. But a lot of those patients are just so sick. They're just like delirious and not doing much anyway. You could also just do like boluses of Haldol. That's a pretty hemodynamically stable agent. Or if benzodiazepines or benzos are pretty stable in a patient who's that close to death. I must admit, I'm still a little nervous about putting propofol on patients that unstable.
All right. The study needs to be done. So the opioids and the recent post on the men's trial in terms of fentanyl drips, would you say at this stage of the game, we just should not be having patients on fentanyl drips outside of potentially a neurocritical care case where you really want to have both the decreased cerebral metabolism effects of the opioids or maybe a post-arrest patient as well? Is there anyone else you really think of who should get continuous opioid drips?
I think I like continuous opioid drips in selected situations. I think the other place where they're really useful is like an asthmatic who's intubated and they're really tachypnic and you're trying to just like break their respiratory drive. So I think there can be situations, or someone who's paralyzed and you're trying to get their RAS down. There are like very limited situations where they're useful, but I think this concept of just like putting everyone on a fentanyl drip, like I was doing that, I've done that in the past and we stopped doing it. And it was a lot easier to stop than I ever would have imagined.
Yeah. Do your nurses have the capability of deciding when to administer more bolus dose opioids, or do you have to order each one?
No, we have PRN boluses, and then they'll just put in verbals under my name. Even when I'm off, I get this list of like PRN of verbal orders, and I just sign them all.
How are they making that determination?
In a perfect world, it should probably be based on like this CPOT score, which is this behavioral pain score designed to sort out between agitation and pain. So ideally, nurses should be assessing patients and saying, I think this is pain, we're going to give a fentanyl bolus. I think this is just agitation, we're going to give some Haldol or increase the propofol. In reality, I think it's probably just more of a bedside gestalt at this point. And we haven't really had great penetration with the CPOT yet.
I think the CPOT just empowers nurses to use their judgment, because in New York, at least, nurses are actually by regulation not allowed to have independent judgment. As a result, if you give them a CPOT score, they could use their gestalt as they would anyway and be justified in it when without it. So if your nurses already don't have that regulation, then I don't think it adds much to the mix. Okay, so we know that while pain is not treated by propofol, patients stop caring about their pain when on enough propofol, and that's how you get to 70 micrograms per kilogram per minute of propofol as your routine ICU management. We also know that opioids at high enough doses, as our heroin users will attest, has sedative effects. And so therefore it becomes difficult to parse out which agent we should actually be increasing on. And both strategies will in some ways work. What is the optimal strategy? Should it be balanced? Should we be analgesia only? Should it be propofol only, as seemingly many ICUs at our institutions like to go with? What's your feelings on this?
I must admit, I like to use a bit more propofol and less opioids. This issue of whether or not you can have pain when you're unconscious, it's almost like a philosophical one. Based on the definition of what pain is, I think it's impossible to have pain if you're like in a rock-like propofol state. So I think like it comes down to using as little medication that's going to cause harm as possible. If the patient's unstable, maybe opioids are more beneficial. You don't want to push up their propofol drip super high and give them hypertriglyceridemia. But I generally do err more on the side of using a ton of propofol and a little bit of opioid just to get people off the ventilator quicker.
Questions from the audience about pain, agitation, and delirium management.
One question for like for instance, your COVID patients. At what point, one of the obvious advantages of a trach is that the patient can be awake, they can communicate, they can ambulate, whatever else. Are you moving toward earlier trach of these patients at all?
I have to say, we haven't had any trached patients with COVID, or the Vermont experience with COVID has been a little unique. And I think it's probably different from your experience a lot. And Vermonters typically don't like tracheostomy, and they will usually transition to comfort rather than getting a tracheostomy. So we haven't had any trached COVID patients. Sorry.
Let's discuss a little bit of PAL care. And you're an intensivist. You get to decide who comes to your unit and who goes to the floor. It's one of the few areas in medicine where these kind of decisions are not completely motivated by the family, right? It's weird. It's like the surgeons could decide who to operate on, the nephro folks could decide who to dialyze, and the intensivist could decide, wow, this patient won't get an ICU bed. It's one of the few empowered areas where the family can't overrule your judgment in a very easy fashion. So are there patients who are not candidates for an ICU bed, even though they're really sick? And I'll give you the first example. Patient long-term care facility, no ADLs. Do you ever accept that patient to your unit?
So first of all, this is like a totally foreign question for me because the way things work here, I have no say over. I could not refuse a patient like this.
Oh, really? So then
No.
tell us how it works.
Basically, if they're unstable enough or if they're on mechanical ventilation, they'll just come to the ICU. I can't block them.
If they're intubated, it becomes harder to block anywhere.
Yeah.
But let's say the patient has not had a tube yet. They're just really sick. They're on norepinephrine.
Yeah. If they're on pressors or high flow or BiPAP, they're all just going to come to the ICU.
Okay. So then that makes it in some ways easier and less frustrating. So then what do you do with that patient when they get to you? Do you give a trial of critical care? Do you immediately tell the family this is not appropriate care? What's your thought process on that?
It's really challenging. I think the first question is, what's the overall situation here? Is the patient acutely dying?
Yeah, they're super sick and their baseline no ADLs. They're just
Yeah. If they're really acutely dying, I think the best thing is really just to talk to the family and try to explain that there's really no real benefit of providing aggressive care for patients in this situation. We may just be prolonging their suffering. and we're probably going to do more harm than good. And I think most people will, if you explain to them what the situation is, I think the vast majority of people will come to terms with that. There are a fraction of the population who will not, and that becomes ethically problematic.
So for the first time in the setting of COVID, we've been empowered to actually identify inappropriate care and actually overrule family wishes if we have run out of ICU beds. Now, even without COVID, oftentimes we've run out of ICU beds. What is your threshold to say this care is inappropriate regardless of family wishes, even if you're not actually empowered to go with it? What is just your philosophy on that?
I think probably a major driver is what the patient's baseline is, because whatever their baseline is, they're like, if they do okay, even if they survive their critical illness, they're going to be sicker than their baseline. People don't leave the ICU better than they were before. So if someone has a miserable quality of life and they're unable to take, pleasure in anything, then I can guarantee you with 100% certainty that even if they are able to survive their ICU course, they're going to be sicker than that. So I think for those patients, you can make a pretty reasonable statement that you're not going to benefit from critical care.
All right. Any questions about pal care stuff before we move on to the big elephant in the room? All right, that elephant's COVID, Josh. And you've done more than anyone of keeping me informed about what actually is going on rather than what the press releases say. It's a joke. This disease has revealed our medical system to be in some ways farcical in its current form, when the CDC and WHO are telling us masks don't help. And then, oh yeah, masks do help. We were just lying to you in order to get the mask saved. I mean, it's a violation of everything that medicine's supposed to be about. You've published so many blog posts that have debased things in major journals that have come out in as a positive. And when you actually look at the study, they're clearly not. Let's go through it. What's steroid and when, based on the best available evidence?
So I think everyone should probably get at least 6 of dexamethasone. And this is assuming, by the way, patients are coming in with COVID. One thing that we're starting to see now is patients who had COVID, they got discharged, they're coming back and so on. But assuming patients coming in with acute COVID pneumonia, I think 6 of dexamethasone is your minimum rock bottom. What I'm doing, my kind of concoction that I've been using in my hospital, and I think this needs to be coordinated with your folks at your hospital. I don't know what protocols you have. My rheumatologists love baricitinib. So basically everyone is put on baricitinib. Everyone gets 6 of dexamethasone. If their CRP is really high, or if it's going up, what I will do is I will give them little boluses of 125 milligrams of salmeterol a day, because nobody realizes that. So if I was to put them on 20 milligrams of dexamethasone, everyone's brain would explode. But I can give a push a day of 125 of salmeterol, and nobody realizes. And I'll do that for a couple days until the CRP is trending down. Then I'll stop with the salmeterol, and I'll kind of just leave the baricitinib and the dexamethasone.
Paul Marek's on a whole screed that salmeterol is the agent of choice for COVID, and that the dex has been a big mistake. Does he have anything behind what he's saying, or do you not agree with that?
I don't necessarily agree with that. I think it's really just a matter of the dose. I think 6 of dexamethasone is a pretty inadequate dose for a lot of patients with really severe COVID. So I think you'd be perfectly fine going with a 20 milligram dose of dexamethasone. I like dex. I think it's nice. It doesn't have a lot of sodium retaining properties. It auto titrates itself in a really clean way. And I'm not aware of any evidence in the pulmonary realm comparing equivalent doses of steroids that show that one steroid is better than another steroid. The real study that we need is something comparing 6 of dex to 20 of dex, and I don't think that's been done.
Brian, you had a question?
Yeah, let's say you've given hydrocortisone for stress dose. Would you then go to a mineralocorticoid after that, or would the hydrocortisone be? I'm sorry, with glucocorticoid, with the dex, would you go to dex after that, or just continue the hydrocortisone?
Yeah, I'd probably just transition to dex. Most of these folks, I don't think that they really need the mineralocorticoid. They're going to tend to retain sodium. They're going to get a lot of IV fluid. So I like the pure glucocorticoid of dexamethasone. It allows them to hold on to less fluid.
Okay. Anticoagulation. What do you do, and what do you use?
So this is so hot now, and it's really frustrating because the Active 4 trial is probably about to break. I think for patients on the floor, probably that study is going to show that therapeutic anticoagulation is the way to go, but it hasn't been published, and I don't want to make a recommendation based on the press release. For critically ill patients in the ICU, my current practice is to use 0.5 mg per kg enoxaparin BID, and that's supported by a lot of evidence in the critical care world. And there's a blog that goes through all of that evidence, and essentially when you're sicker, even if you don't have COVID, you develop heparin resistance, and like 40 milligrams of enoxaparin a day just is not enough for these patients. It probably was never enough for them. So I think right now, today, 0.5 mg per kg BID of enoxaparin for someone with normal renal function is a pretty solid way to go. It's supported by a reasonable body of evidence. So if someone was to challenge you on it, you could show them a bunch of studies.
My take, and I'll ask you the same question. If I got COVID, I would want to be on a full dose DOAC, and I would just prescribe it for myself right off the bat. What's your feelings? Because neither of us have any contraindications. We're probably not going to fall on our head during our COVID spell. I don't see a downside.
I'd probably go for, I agree with you. I'd probably go for full dose enoxaparin though. I think there's some like interactions of heparin with the endothelial glycocalyx, and like there's some goodness I think that comes with the heparin that's different from the DOACs, but I agree with you.
So you'd be giving yourself a shot once a day.
Yeah.
Yeah. So then why, it always strikes me as so dispiriting when what we would do for ourselves is not what we're doing for our patients. And so is that disparity a problem?
Yeah, it's a problem, but I think this has been like the whole problem throughout the COVID epidemic, which is that things are changing so quickly. We have all this partial information. It's like on the one hand, we want to change rapidly, but on the other hand, if we're changing too rapidly in response to press releases that aren't giving us the full picture, then we're just going to be whipsawing all over the place. So it's really frustrating.
All right. Is there any benefit that you have found, and we'll go through inpatient and outpatient. Let's start with inpatient, for remdesivir, the MABs, the NIBs, any of this crap that is so expensive. Have you found any that we should be using?
So I think remdesivir is just, in my opinion, it's just crap. There's one positive, it's like the TPA for stroke thing where there's one positive trial and it's just not replicated. And then people keep on referring back to that original trial. So I hate remdesivir. Folks in my hospital, it's part of our protocol. And if I don't put people on remdesivir, like the ID folks are just really upset about that. So I am, just like full disclosure here, I am putting people on remdesivir, but if they have that contraindication to it, I'll try to get rid of it. As far as the MABs in the plasma, I think is crap just across the board. Don't bother with it. There is probably about to be one study coming out showing that Regeneron may be beneficial if you give it to someone before they get sick. So like theoretically, if you got like some huge exposure to COVID, you could get Regeneron before you got sick. That's just like a press release. I don't even know if it's reality. But as far as managing sick patients that we see in the ER or in the hospital or in the ICU, I think all the MABs are crap too.
So we've had a ton of patients come in for their BMAB and for their outpatient. And in fact, it's such a pain in the ass to give these medications. Why do you think that's going on, and how do we make it stop?
People want to do something. People are sick. We want to do something. The folks who get sick are anxious. They want to get therapy. So there's this duty. We want to give them something. And I don't know if there's other motivations as well. Obviously, the drug company is trying to make money. I don't know if hospitals are making money off this. I can't imagine that they are, but I don't know how they're billing for it. But the whole MAB situation is a disaster. And I don't know how to make it stop.
Paul Marik has been on a nationwide crusade to get everyone to feel that ivermectin is the salvation for COVID. It has a low side effect profile. Should that be what these patients are receiving so they feel like they're getting therapy?
There's no high quality data showing that ivermectin works. And we've rotated through all of these different things of the hydroxychloroquine, azithromycin, different MABs, convalescent plasma. And I think eventually people are just going to lose faith in science. I don't think ivermectin is super toxic if the family or the healthcare system is like demanding that you give it, or they're going to sue you or whatever. But I think this is just undermining us as scientists.
Absolutely. Other questions from the audience about COVID related stuff?
I have a question. I'm in shock right now, obviously, and that's why I'm living in this chair. But my question is, I heard them mention something that I hadn't heard before, and I'm sorry if you done a podcast on this and I haven't seen, but they're saying now after a certain amount of days or 21 days that even though people continue to test positive, that their actual viral load that is able to replicate and get other people sick is not detectable. So even though people are still super sick on the vent with like horrible lungs and whatever, they're just going in the rooms now like raw dog with a surgical mask, and that's it. And it just, I don't know, it makes me feel uneasy. So
there is this thing where people continue to shed mRNA for like weeks or months. And we've encountered this, and it's super frustrating. Like we'll have patients who they get COVID, they go to a nursing home or a SNF, and they come back to the hospital like 2 months later with like heart failure or something random, and someone will swab them and it'll be positive. I do think that once someone is COVID positive, they may continue to be COVID positive like for long periods of time. And the evidence is showing us that those patients probably don't have live virus in their nose. It's just RNA. I haven't done like a deep dive on this. I've just been referring this to my infectious control policy folks, but I'd probably follow whatever policy is at your hospital. If your hospital folks are saying they're safe, I probably wouldn't worry about it. And honestly, I think probably most of the patients that I'm seeing in the ICU, like they're usually like 7 to 10 days into this illness, and their viral load is probably falling pretty substantially. So I'm not that worried that the ICU folks are going to get COVID. I think the real people who are going to be spreading COVID are the folks coming into the ER who are asymptomatic carriers or people getting bamlanivimab. They're going to be spreading it everywhere.
Other COVID questions?
Yeah, they said there was a study done, and I got home after my shift and I started Googling around, but I haven't found whatever that study was. So maybe I'll ask them to show me what they're talking about the next day or so. But yeah, I don't know, it made me feel a little uneasy.
I think you're probably okay as long as you're following your institution's ID protocols.
Yeah. Thanks.
I have a question. We're throwing a lot of like empiric, like community-acquired pneumonia coverage at these people who probably are just COVID. Are you just discontinuing that immediately when they come upstairs, or are you continuing it for a couple of days?
Yeah. So during the first wave, I think we were pretty worried about the possibility of bacterial pneumonia, and the typical cocktail would be like people would come in, they'd get ceftriaxone, azithromycin, and then like we'd check a procalcitonin once or twice and peel everything off. Over time, I think we've gotten increasingly comfortable saying these people are positive for COVID. If their X-ray looks like COVID, if it smells like COVID, it's COVID, and we'll just not ever start them on empiric antibiotics. And there's been emerging evidence too that this isn't like influenza. Like there's lots of people who come in with flu and they have a pneumococcal superinfection or a staph superinfection. The COVID patients typically just have COVID.
Other COVID
Josh,
questions?
at what point do you think as all of us are vaccinated, that we can move to maybe just surgical mask and not eye protection and N95s and 20 other things?
That's a great question. I don't know the answer to that. I've gotten used to wearing an N95 everywhere in the hospital, and that's just kind of what I do. I think it's probably super overkill, but it gets back a little bit to this issue of like COVID, positivity. As I think we're all vaccinated, I don't think we're going to be at high risk of dying or doing poorly. But like if I get COVID and like how long do I stay out of work? It would be like a huge logistic boondoggle. I don't know. I'm just wearing like the duckbill N95s everywhere, and they're pretty comfortable. You get used to them pretty quickly.
All right, let's move on, Josh, to another area that you have really evolved on your thinking throughout the years, which is initial vasopressor choices. There was a time when you were putting, or at least saying you were putting everyone on vaso and norepi right from the start, and perhaps even early epi, but I know your thinking on this keeps changing as you get more and more evidence and more practice with what works and what doesn't. What is your stance for initial vasopressor choices and add steroids to that mix?
Yeah. So this is pretty interesting. As far as steroids, I think we've largely moved to initiating steroids very early for septic shock. And the rationale there is not that they're going to save anyone's life, but they just get people off pressors quicker. They get people out of the ICU quicker. And I'd like to say that I save people's lives, and that's my job as an intensivist. But I think fundamentally my job as an intensivist is just to get people out of the ICU. If I get people out of the ICU quickly, I've done my job. So steroids help me do that. As far as pressor choice, we've largely moved to going with peripheral pressors for most of our patients, especially initially. I don't like giving vaso peripherally because if it extravasates, it may be ugly. There's no reversal agents. So that's largely shifted me to using a lot of peripheral norepinephrine. So that's typically what I'll open up with. For someone who is sick and they have a central line, then I think it depends largely on who the patient is, what their heart looks like, stuff like that.
And when are you adding in more agents? Are you waiting until they're already up to 20 or 30 of norepi, and then you'd consider putting a central line and adding vaso? Would you be adding it sooner than that? What is your stance?
That's a good question. I think it depends a lot on the patient. For example, like if I look at the patient, if their heart is like not squeezing well, if their heart rate's 70 and it should be 100 or 120, I might just start them on some epinephrine. I'm not sure how much vaso really adds to norepi. Yeah, I think I'm a little ambivalent on that.
All right. One issue we're wrestling with right now is the super high dose vasopressors and when it's still of benefit. And there's definitely cases that patients just have resistant vasoplegia, but you can fall in a situation of patient actually had other stuff going on. It was actually an inotropic issue or cardiac function issue. What do you do differently once you start getting in the 50 to 300 range of norepi that you weren't doing when you're on 20?
Yeah, that's a little ugly. Certainly fix anything that can be fixed, evaluate the heart, fix hypovolemia, stuff like that. We already talked about possibly shifting away from propofol, maybe moving to some more hemodynamically stable sedatives. I'm not sure if that makes a difference or not. Those are patients where I think vasopressin might be more beneficial, especially if they're like super acidotic. Calcium can sometimes be helpful to limp patients through your shift so that they can code during the next shift. All the patients are going to be on steroids at that point in time. You could start pulling out stuff like epinephrine, depending on the heart rate and the inotropy. I don't find adding phenyl to norepi does much.
I guess my question more is, do you have any instituted vascular or limb monitoring that you add on? Or the nurse is going to do Q1 hour neuro and vascular checks. What do you do differently in terms of making sure these patients aren't going to lose their limbs?
Yeah, so that's a problem. Man, this is being recorded. Hopefully,
I can edit this out. You could say it off the record.
So we should have some sort of protocol for neurovascular checks. We do not. So I don't like to run people on, I don't know, more than 15-ish of norepi for prolonged periods of time. So those patients are probably going to need to get a central line. In reality, we could probably be doing higher doses of peripheral norepi with a protocol, and then you could get into the whole midline issue. This is all just like local practice, and I can't like change it.
And I didn't even mean from the extravasation. I just mean that it's pretty easy to knock off limbs if you miss the diagnosis and they actually were not resistant vasoplegia. They were actually something else. On 150 of norepi, you can lose your fingers pretty easy. Now, if they actually are resistant vasoplegia, calcium channel blocker overdose, or just recalcitrant sepsis, sure, those will be helpful. But if you miss it a little bit and go too far, it's bad. So that's why I was alluding to about the neurochecks.
So a couple things there. So first of all, keep a close eye on the hands. When, if you start getting digital ischemia, I'd be really aggressive about getting rid of vasopressin. I'm not sure that there's like good science behind this, but I feel like the combination of like vaso plus norepi plus cold hands, that's a really bad combination. And I think the other thing that you do need to think about is this is where putting in a central arterial catheter can be pretty beneficial. Past a certain dose of pressure, the blood pressure cuff may not be incredibly accurate, and even like a radial A-line may not be super accurate. So I'm actually tempted to put in what I really like, either these like axillary A-lines or femoral A-line. And sometimes they'll be pretty discrepant, although sometimes they'll be exactly the same. Just like a couple shifts ago, we put in like a axillary A on this patient on like super high doses of pressure, and they were exactly the same. And everyone was like just making fun of me for it.
It's funny because that brings up a big issue, and we stress these central arterial lines a lot when I'm doing my teaching, is if they were the same, what you've proven is your high doses of vasopressors were actually the right choice. The patient does indeed have retained vasoplegia that needed those high doses of vasopressor. It's when it does reveal something discrepant that you've probably saved that patient's hands, because the problem was that the blood pressure was falsely low due to the vasoconstriction itself. And then it's a vicious cycle. So I don't think you lost anything by proving that they were matching. In fact, one could probably argue a study could be done of the continued matching of a radial and femoral art line as the indication that you're safe to continue using these incredibly high dose vasopressors. And
yeah, absolutely.
That would be cool. All right. Peter's asking, does dopamine have any purpose in intensive care anymore, or should this just be retired to the dustbin?
I don't know. Do you need to like hold open a door or something?
All right.
That being said, yeah, I mean, I think I've seen one patient who seemed to respond to dopamine. So I think if you had a patient who was like legitimately dying and they were on every other pressor and you wanted to like just throw one last thing and you don't have angio, I don't have Ange, I might, but honestly, I haven't used dopamine for years.
All right. Let's go to an area.
Can I ask a question?
Yes, you may.
Yes, it's a philosophical question, but then more specifically for pressors. I think though in emergency medicine, there's generally two types of emergency physicians. Those are really trained in critical care. And then there's the more old timers who are based on their clinical experience And at our own institution, there's been a lot of discussion between like Billy Mallon, I don't know if Billy Mallon and Scott Weingart about these issues. But the philosophy is a lot of the critical care trained people focus a lot on physiology. And at some point, maybe missing clinical, I think. And where's my example? Is you got a lot of old people who come in, their blood pressure's in the 80s, but they're putting out urine, they're mentating, and if you even get a lactate, their lactate's normal. And the question is, do you really have to push these physiology like the MAP of 65, or can you leave that patient alone if they're mentating and they're putting out urine? We know that from many Rivers stuff, the super physiological goals and pushing people to physiological goals may not be great. So where does clinical decision-making come in as opposed to just focusing on physiology, and especially with pressors?
Yeah, I think you could, certainly titrate pressors against clinical response. The 65 trial showed that a MAP of 60 is probably just about as good as 65. And if you have a MAP in the high 50s and the patient's doing well and producing urine and mentating, and I think that's totally fine. One challenge is when you really get down to the brass tacks of it, a lot of the evidence that we have for these things is really not tremendous.
Yeah, to go further on that, the reason most intensivists wind up dealing physiologically is because there's not a great evidence basis for 99% of what we do. And you want to be as protective as possible. Avoiding iatrogenic injury is the hallmark of a good intensivist. You want to minimize the patient's condition, but you also don't want to be the cause of any additional harm. And when you get a critically ill patient whose MAP is, and I agree with Josh, 60 may be a reasonable number if you want to give them some permission to not get to that 65. But below that, we know the time it takes to get kidney injury is remarkably short, and that's going to happen way before the urine starts disappearing. So maybe I'm just defending the practice I've pushed here, but I don't, the patient you speak about, Adam, in my mind, is a patient who is not critically ill. And certainly you don't have to take every old person who has a MAP of 59 and go crazy. But in a sick patient who has multiple other hits stacking up, I don't think you should leave a patient with a MAP in the 50s for any period of time. Josh, is that unfair?
Absolutely.
Okay. I have 3 questions from Garrett, who seemingly is too shy to ask them, so I will pose them for him. And I'll say all 3 because I know your mind is capable enough, Josh, to remember them and answer them in kind. All right, 3 questions about vasopressin. Is it actually renoprotective? Is it actually a pulmonary vasodilator? And is your max dose always 0.04 or do you push it to 0.06?
Yeah. Is it renal protective? I think there are a couple RCTs that show that patients randomized to get vaso have lower rates of acute kidney injury. So I think there's some evidence for that. It's probably applies predominantly for patients who need a vasoconstrictor. If the problem is vasodilation and you want to use a vasoconstrictor, I think you could make a reasonable evidence-based argument that it's maybe a bit better for the kidneys. Pragmatically and in reality, I'm not sure that it makes a huge difference, but that is what it is. Is it a pulmonary vasodilator? I think that it is. I want to believe that it is. I'd like to believe that it is. I think it's a good choice for people who have pulmonary hypertension because most of the other drugs that you're going to use for pulmonary hypertension, or most of the other pressors that you're going to use, are going to cause pulmonary vasoconstriction. So, for example, an alpha agonist like phenylephrine or potentially norepinephrine, not quite so much. It's going to vasoconstrict your pulmonary vascular bed. It's going to make the pulmonary pressures higher. Vaso may theoretically reduce your pulmonary pressures, increase your systemic pressure. I'd like to believe that's the case. As far as the last question, max dose vaso, I'll routinely go up to 0.06 of vaso for patients with hepatorenal syndrome. I think vaso is, if there's one place where vaso is a great drug, I think it's hepatorenal syndrome. Those patients really need like a lot of vasoconstriction, a lot of blood pressure. I'm not sure, honestly, that there's like any max dose for any pressor. I've had patients who've been sick and dying and we can't get their blood pressure up and you go up a little bit higher than that. If the choice is between the patients dying and using higher dose, you do what you got to do.
Would you keep them on the 0.06 once you added a second agent like norepi to the mix?
For hepatorenal, I would. I think that's really like your frontline agent. For most other situations, probably not.
All right. One more topic, and then we'll open up the free form questions. Submassive pulmonary embolism. Now, given the druthers of any of the proceduralists, they'll tell you, oh, these patients all need catheter-directed lysis, clot retrieval, or an ECOS catheter, if that does anything different than a pulmonary artery catheter. And you've been a propagator or promulgator of the fact, and the fact I believe, that there's no difference between giving these agents through a PA catheter or a peripheral line after the first pass. Should any patients be going to catheter-directed lysis? Or if the studies got done, should all patients just be getting peripheral doses of TPA that matched what they would get through a pulmonary artery catheter.
Yeah, I don't think any sort of like these IR procedures that just deliver TPA, I don't think they're worthwhile. So personally, my preference would be to never use these like the Ecos catheter, stuff like that. I think it's complete crap. And I would probably just peripherally infuse TPA. Now, that being said, my institution has come up with protocols and I've gotten a moderate amount of pushback about using TPA infusions peripherally. So sometimes I will go the IR route just to satisfy the powers that be. And that's an issue in and of itself.
There was that one trial done by a cardiologist, I think it was European, that you like referred to me to try to convince him to publish. It's baffling because they published an abstract and it was like the perfect protocol. It was like quarter dose over 6 hours. So it's quick enough that you don't have to rot for a day to see the effects. And it's also not that 1 hour, 50 milligram alteplase. And they tried to publish it in one journal, the abstract's in the literature, but they tried to publish, the journal said no, and they just gave up. And they haven't answered my emails. Someone's got to do this trial, Josh. It could be you. What, if you had your druthers, what do you think the optimal peripheral infusion for sick submassive is? Meaning that maybe they were hypoxemic and require a lot of oxygen, or maybe they're not quite on a vasopressor yet, but their pressures are a little soft. What is the ideal peripheral infusion?
I think it depends a little bit on just how sick the patients are. And the patient, this is challenging because obviously it's not like a dichotomy. It's really more of a gradation. There's some submassives who are really high risk and they're really almost at the verge of being a massive. So for like your super high risk submassive, I think giving them like just 50 milligrams of TPA over 2 hours, they have lactic acidosis, they're tachycardic, they look sick, you're worried that they're going to code. So I think like 50 over 2 hours is probably reasonable for them. But then you have this other group of patients who are like intermediate submassive where they look okay. They have a lot of indicators that they could have a cardiac arrest. Maybe their lactate's 3. I think giving like 25 milligrams over 6 hours, something like that, or 50 milligrams over 24 milligrams over a day, some dose of TPA would probably be good for those patients. What I hate doing is admitting a patient for submassive to the ICU and just giving a pepper. And I find that to be dumb because if the patient is sick enough to need to come to the ICU, I feel like we should be offering them some sort of therapy, because we've had patients who've come to the ICU, hung out for 24 hours, go to the floor and then die. And there's nothing definitive about if you're going to die, you're going to do it within 24 hours. You can absolutely do it after that.
Have you found any of the prediction rules to be helpful in those circumstances, or are they all garbage?
I don't find the prediction rules to be helpful. There's a lot of emphasis on the PESI score. The PESI score is like metriced out for 30-day mortality. So it's largely weighted by like age and gender. So like you can be like a 90-year-old male and have a tiny PE and your PESI is going to be huge. You can be like a 30-year-old woman who's like about to die and your PESI is going to be low. So I find that to be unhelpful. I think just looking at all the different pieces, hemodynamics, echocardiogram, look at CT scan, just gestalt. That's how I go.
All right. I lied about this being the last topic. One more topic. Who should we be giving bicarb to for anion gap metabolic acidosis?
I think the only person with an anion gap metabolic acidosis who would benefit from bicarb are uremic metabolic acidoses. So your lactic acidoses, your ketoacidoses, you need to treat that. Uremic acidosis is frustrating because like those patients are going to take a while to get better. And I think the bicarb ICU trial gives us evidence to say if someone has uremic acidosis and their bicarb is like 14 or pretty low, that's a reasonable thing to do.
Let's say you had a patient with a lactate of 5 and they're septic and you've determined they need more fluid. Now, at that stage, giving them isotonic bicarb as their fluid, it's a slightly different situation than de novo just giving them bicarb therapy. Would you give that patient, you've decided you want to give a fluid bolus to isotonic bicarb, or would you say, no, I'm going to be strictly evidence-based here and give them something like Plasmolite or lactated ringers, which in essence, we're trying to give them bicarb just in a form that requires conversion?
I would probably go with Plasmolite or lactated ringers, assuming that there's not some combination of like anion gap and a non-anion gap.
All right. Let's open it up to the group. Any other questions you want for a deep thinking intensivist?
Ever use albumin?
Yeah, I think albumin is evidence-based for hepatorenal syndrome. So I definitely use it for hepatorenal syndrome. Out in large volume paracenteses, stuff like that, I do not use it outside of that. I don't think it's supported by good evidence. And it's one of these things that just like keeps on getting kicked around. Yeah.
You're blanking on the most important reason to give albumin, Josh, which is when you're an ICU fellow and you want to give the patient more fluid, but you don't want your attending to yell at you. for the eyes and O's not matching up.
Josh,
Go ahead.
Josh, for your decision making about who gets TPA with a submassive pulmonary embolus, it's close, not arresting, but you're worried that it may happen. I've not found anything in the decision rules that where your decision making would be altered by the amount of volume of clot that's in the legs. Would that make sense to you to take that into account?
So there is evidence that people with big clots in their legs have increased mortality. So that is a risk factor for mortality. And that might push me toward giving someone TPA. So I'd be worried, if they're really struggling to deal with the clot in their lungs now and they have a huge clot in their leg, if they embolize that clot in their leg, they're going to be probably dead. So that would push me toward it.
Do you think people where you've diagnosed a PE should routinely get Dopplers of their legs?
That's a really good question. So that being said, I just said one thing, I'm going to contradict myself, but that's life. I usually don't routinely Doppler these people like up front. Theoretically, I guess it might make it's not a huge driver in my decision making.
Other questions for Josh?
Could you talk a little bit about de-resuscitation and fluid overload in the ICU and what you do if just plain diuretics isn't working for you?
Yeah, certainly you could start with furosemide. If that doesn't work, you can add on things like a thiazide diuretic, something which I think is probably underutilized and I find to be an interesting concept are sometimes we get these people with RV dysfunction and a really high central venous pressure. And I think the problem is that their renal perfusion pressure is basically the MAP minus the CVP. So I think there is a population of people out there where if their MAP is 65 and their central venous pressure is like 25, they're just not driving enough blood through their kidneys. So I think some patients may require like a little norepi to get that MAP running through the kidneys to get them to diurese. I did a blog on this hypertonic saline hyperdiuresis thing, and I haven't yet encountered enough patients where I tried that to know if that's going to work or not.
Let's go on that a little further. I don't know if your ED is profligate or not with fluids at UVM, but are you doing a Vexus exam ever? And if so, or if not, are you acutely, aggressively diuresing patients that come up from the ED?
So yeah, I'm definitely looking at the IVC. I got to admit, I went to like the conference with Montreal and the portal vein, and it's like beautiful. My ultrasound machine I just struggle a lot with the portal vein. I don't know if it's just the machine or something.
No, I think that's everyone, but hepatic vein's not that bad.
Yeah. So I think, but I do base a lot of this on the patient's history and the amount of fluid that they've gotten. So if someone's gotten 3 liters of fluid, I can probably pull off a fair amount of fluid. We get these people from outside hospitals where every single interhospital transfer I get from an outside hospital, they've been there more than a couple of days, is going to be like 10 liters positive. And we'll just start them on like multiple diuretics, just rolling in the door.
And you're doing that just based on history and what they look like, but you're not necessarily going on a calibrated ultrasound assessment.
Not really. We'll keep an eye on their IVC occasionally, look at their hemodynamics, stuff like that. But we're probably not doing it as scientifically as we could be.
All right. I think we have time for 1 or 2 more questions if anyone has them.
Yeah, I have a random kind of broad question. I couldn't help but notice all the stacks of paper on the floor behind you. So like you're pretty productive. You write these long blog posts. So what kind of system do you have to stay organized, or do you have a writing routine, or how do you evaluate even papers? It's broad, but
yeah, I just spend a lot of time working. I don't have any good tricks for it. I'm probably not a good person to model being efficient against.
I think your efficiency is amazing. I think if you're not the ideal role model for a balanced life.
Yeah. Okay. There you go.
All right. Other questions? All right. Well, then let's wrap it up there. Josh, this has been an honor. Amazing.
Oh, thank you.
It's one of my greatest privileges that I could go to my own blog and learn every time you put up a post. So I can't tell you how happy I am that you're out there and doing what you do.
Thanks, man. You're far too kind.
All right. Let's have a round of applause for Josh Farkas. We're all muted, so it's a single golf clap. Okay. All right, buddy. Talk to you soon.
All right. Bye-bye.